Well, let's go ahead and get started. Hello to everyone that has joined the webinar. Thank you for attending today. Today, we are going to talk about clinical mitigation strategies for Medicare set-asides. This is a really timely topic. Obviously, a lot of developments coming out of Medicare recently. We're going to have Medicare set-aside reporting starting next year. We're going to talk about that in a moment, but now is a really good time to make sure you've got a good handle on making sure that your Medicare set-asides are coming in at a reasonable cost, and that you're getting in front of your settlements and making sure that you get a reasonable MSA at the time you're ready to settle your claims with Medicare beneficiaries. I'm delighted today to be joined by an amazing panel today. We have Brenda Smith and Deanna Lawrence. I'm going to tell you a little bit about both of them. First off, Brenda Smith, she's our Chief Operating Officer. She joined us earlier this year in April of 2024. She has over 30 years of workers' compensation experience, and 19 of that focused on Medicare secondary payer compliance. She specializes in clinical mitigation, and she has been in the space for a long time. Brenda does a great job managing our operations. She has great thought processes, great attention to detail, as well as communication skills. As the operations lead here at Sanderson Firm, her expertise in process improvement and quality assurance ensures those great MSAs that we're getting here out of Sanderson Firm. She's Medicare Set-Aside Consultant Certified. She has also achieved her Medicare Secondary Payer Accreditation, also known as MSPA, which is a great accreditation that Sanderson Firm has been offering through the last year. All right. Also joining Brenda today is Deanna Lawrence. Deanna joined us at Sanderson Firm in 2022. She has well over 20 years of experience in the work comp industry. She's allocated all types of different allocations for future medical, Medicare set-asides, life care plans. She has advanced within Sanderson Firm. She's been an amazing asset to us here at Sanderson Firm, and so she's been promoted multiple times, and she's now our Assistant Vice President of Clinical Services and oversees our whole clinical department, our mitigation department. She has a wealth of knowledge. She is also known for her attention to detail. Both of these ladies here have great attention to detail, and she values quality work. And she is a licensed nurse. She's also a Medicare Set-Aside Consultant Certified, as well as MSPA. And she noted in her own biography that she wrote that she's grateful to work with some of the most talented people in the industry. So we couldn't agree with that with Deanna here at Sanderson Firm. She's working with a great team. So I have a great panel here today. Myself, for those of you that don't know me, my name is Heather Sanderson. I'm the CEO and founder of Sanderson Firm. I've spent my entire legal career in Medicare secondary payer compliance, well over 16 years now. About 4 years ago, I founded Sanderson Firm, and we are a law firm specializing solely in Medicare secondary payer compliance services. We are a woman-owned firm. We are known for being consultative and innovative with our approach to Medicare secondary payer compliance. And I will say it for sure, our Medicare set-aside is our most demanded product here at Sanderson Firm. And we have a variety of great Medicare set-aside options here at Sanderson Firm to suit all different types of settlements and all different types of various risk tolerances. So we're happy that you came to listen to our webinar today. Just a quick few housekeeping items. We're happy to take questions. If you have questions, please do populate them in the Q&A function of Zoom here, and we will get to those at the end of the presentation. Also, there will be a survey that you will receive post-webinar that will ask you what you thought of today's webinar, what you would like to hear from us about in future webinars. We appreciate you filling that out for us today. Thank you so much for joining. Let's go ahead and get started. So our agenda for today, for those of you that might be newer to Medicare set-asides, we're going to kind of lay the foundation and talk about what MSAs are generally. Then we're going to go through the recent CMS submission statistics, what Medicare is telling us about Medicare set-asides that have been submitted to them for review and approval. We're going to talk about some recent trends with the Workers' Compensation Review Contractor, also known as the WCRC. The fun debate between traditional and non-submit MSAs. We're going to talk about the WCMSA, that stands for Work Comp Medicare Set-Aside Reference Guide, and the WCRC allocation practices. Brenda and Deanna are going to do a deep dive into common cost drivers that they see in Medicare set-asides. We're going to go through mitigation approach and strategies, as well as outcomes and impact. And then we're going to tell you about a new certification in Medicare Set-Asides that we are just starting to launch and release to the industry. So let's go ahead and get started. So Medicare Set-Asides generally, an MSA allocates a portion of an injured worker's settlement funds for all future claim-related medical expenses that would otherwise be covered by Medicare. And they're commonplace in work comp settlements, right? Especially since in 2001, when the Centers for Medicare and Medicaid Services released what's known as the Patel memo. This was the memo that came out in 2001 in which CMS told the workers' compensation industry that they needed to protect Medicare's interests by way of a Medicare set-aside. And Medicare set forth at that point in time certain thresholds for submission in which CMS would review a proposed MSA. MSAs are a settlement tool in both work comp and liability settlements for making sure that the future aspect of medical care is taken care of and the burden is not shifted to Medicare. So what was a really good development that we saw out of CMS is 2022, I believe for the first time, CMS released their submission statistics, and then they released them again last year. And it's very telling for us and very helpful for the industry to know what the average counter high is from CMS if you submit an MSA to them, and how many submissions are they receiving annually. So what we found out last year in 2023 is that on average, CMS's approval amount is currently about 22% higher. So you should know going into submitting an MSA to CMS that you're going to expect an average counter high of 22%. Now, this amount went up because in 2022, CMS told us that their average counter high was 17%. So the amount has increased. Medicare is allocating even more. So that's something that you should certainly be aware of if you're going to submit an MSA to CMS. You will also see on the screen here on the right, you can see the number of MSAs submitted year over year since 2020. If you look at fiscal year 2020, you'll see just over 16,000 MSAs submitted. And then just last year, just close to 16,000, a little bit over 15,743 submissions. So, generally we're seeing here at Sanderson Firm kind of a mix, right? There's some payers, work comp payers that would like to submit MSAs to CMS, and that's their preference. And some of them have continued on with that. Many have been opting to do a non-submit MSA, protecting Medicare's interests without CMS review and approval. And we believe that's why overall submissions have gone down. Also, Medicare's review practices. I mean, the proof is right there in black and white. If you submit an MSA to CMS, you should expect about a 22% counter high, and that's not really very palatable to settling parties looking to settle for a reasonable amount. So we appreciate CMS releasing these statistics. It will be interesting to see what the 2024 statistics show when they release them next year. So the Workers' Compensation Review Contractor, also known as the WCRC, they are a private entity hired by the federal government to review MSA proposals. Medicare did review the contract, renew and review the contract for Capital Bridge. They're the same contractor here at the WCRC that has been in place for, I think, Brenda, correct me if I'm wrong, has it been close to 10 years they've been the same contractor?
Yeah, they've been in place for a while now.
2017.
2017, thank you. Yeah, so I mean, I think there's a lot of good that comes with that, the devil that we know, if you will, right? So that's the good thing, right? Because we've seen for all three of us who have been in the MSP industry for a while and experienced a different contractor where they got really inundated with MSAs and got very behind. It's good to know because, while the Capital Bridge group is not perfect, we are experiencing reasonable turnaround times. Even though, the counter highs are coming in at 22% higher. That's not a great thing, but that's to be expected where Medicare reviews an MSA and they allocate in a worst case scenario manner, right? But the good thing, again, is the stability of having the same contractor and knowing what to expect. Okay, so let's talk about traditional versus non-submit MSAs. So just like a traditional MSA that's submitted to Medicare, a non-submit MSA, they function in the same regard, right? They allocate a portion of an injured worker's settlement funds for all future claim-related medical expenses that would otherwise be covered by Medicare. The difference is, namely, non-submit MSAs are just that. They're not submitted to CMS for review and approval because CMS's review process is voluntary, completely voluntary, even if the settlement meets review threshold. And typically, non-submit MSAs are prepared using evidence-based medicine, meaning that evidence-based guidelines such as ODG and ACOM or state-specific guidelines are applied to the allocation, resulting in a more reasonable allocation and in a more reasonable approach to what that injured worker's future medical needs might be. And interestingly, Medicare's own written guidance, the WCMSA reference guide, even notes that the WCRC does reference evidence-based guidelines as resources in determining future treatment. So even according to Medicare's own guidance, evidence-based allocations are defensible and appropriate. And non-submit MSAs have become a more popular option due to the fact that we're not dealing with CMS turnaround times, we're not dealing with limited appeal options, and also we're not getting those crazy 22% counter hires coming at us when we're trying to settle a case. Like I said, currently the turnaround times are not bad. If all documentation is received, it's about a 2 to 3 week turnaround time. But the limited appeal options are real. If you submit an MSA to CMS, and you disagree with their allocation, you have limited recourse. Whereas if you do a non-submit MSA, you're leaving open your due process appeal rights for later if Medicare does ever challenge the MSA. And typically the non-submit MSAs are going to offer cost savings, right? And with the evidence-based methodology, it's a more appropriate regimen of treatment for the injured worker that seeks to improve their condition rather than harm them, right? So for example, in instances where a physician prescribes opioids to an individual, Medicare is going to, if they review an MSA and they see this person taking an opioid, they will allocate for that opioid at the same dosage and frequency for the rest of that person's lifetime, which we all know is harmful. And so with evidence-based medicine, we're going to incorporate tapering and weaning of those drugs over time. We will strive to make sure that the regimen is decreased over time, where there's some more beneficial or therapeutic alternative. We want to make sure that we're applying these evidence-based guidelines in such a manner that it would improve the outcome of the injured worker. Whereas Medicare just says, if there's any possible chance that this individual might need this prescription drug, this surgery, this particular treatment, Medicare will put it in the MSA, even if it's unlikely that the person will need it. So non-submit MSAs are a more reasonable approach to allocating. And we're also bypassing CMS's strict requirements around state law. So what's interesting is that within Medicare's guidance in their WCMSA reference guide, they state that they recognize state-specific statutes, and they'll also address those statutes that address the limits of future medical treatments, such as Georgia or Maine, right? So for Georgia, for example, they have a law, a workers' compensation law that limits their non-catastrophic claims to 400 weeks. And so what CMS says is that they will abide by that so long as the parties submit an evidentiary court order along with the CMS submission in which the judge says that the parties meet the criteria of the state law. But we have seen, honestly, we have seen CMS disregard court orders, and we have seen CMS disregard state law. So, sometimes it just depends on which WCRC reviewer is reviewing the MSA submission on that particular day. But nonetheless, it can be hit or miss. And it's unfortunate that CMS at times does not abide by state law or court orders as they say they do, because truly workers' compensation claims are within the purview of states, and compensability and liability are a matter of state law, not a matter of federal law. Certainly, work comp payers that settle claims with Medicare beneficiaries need to abide by the Medicare Secondary Payer Act and need to protect Medicare's interests. But I think that Medicare takes it too far sometimes when they don't listen to and abide by applicable state law. So current landscape of non-submit MSAs. So some of you might have heard or been aware of the fact that in January of 2022, Medicare added a new section to the work comp MSA reference guide, seemingly discrediting non-submit MSAs entirely and seeming to indicate that they would not recognize them. They later amended that language and backed up a little bit and revised the language in March of 2022 to say that they may disregard the non-submit MSA if it is deemed to be a burden shift to Medicare and the allocation was not appropriately allocated for and exhausted. So that was almost 3 years ago. This coming January of 2025 will be at 3 years from that. And we are not aware of any known challenges to non-submit MSAs. I personally have been working with non-submit MSAs for well over a decade. I've not known of CMS ever challenging those. We've never had any of them challenged here at Sanderson Firm. We do a lot of industry networking with other individuals in the MSP and insurance industry, and we talk with folks about this, and they have not seen any challenges either. So we believe that's a good thing, but okay, we don't know what the future will hold. It's possible that a non-submit MSA could be challenged in the future, but we believe if the non-submit MSA was prepared appropriately, as we do here at Sanderson Firm, right? We are making sure that our MSAs that they make sense, that they're in line with evidence-based guidelines. That if CMS was to ever question one of our MSAs, that we have all the documentation to defend our MSA as to how and why we allocated the way we did. Our indemnified MSA, which we also call our IMSA, which is a non-submit evidence-based allocation, in which we agree to indemnify all parties to the settlement should CMS ever challenge the MSA, continues to grow in popularity. It is our most popular MSA product that we have available, and it's a great one because we're agreeing to stand behind our allocation. All the parties are protected, and parties are able to settle much more quickly and without those issues that we have at CMS. So now currently Medicare has shifted its focus to the potential reporting of work comp MSAs via Section 111 reporting. We know that that's now going to be a requirement as of April 4th of 2025. Medicare is going to require both submitted and non-submit MSAs to be reported part of the Section 111. But we'll talk about that a little bit later in the presentation. Actually, we're going to talk about it now. I forgot where the slide was coming up.
No, we'll absolutely discuss these new MSA Section 111 reporting requirements. So as Heather said, expansion of the Section 111 reporting requirements to include workers' compensation MSA information for Medicare beneficiary settlements is effective on April 4th, 2025, which will be here before you know it, actually. And you might be asking yourself, well, why do they want this information? And the reason for that is for coordination of benefits issues and just lack of communication by the settling parties. CMS wants to make sure that they have the work comp MSA information so that they can properly coordinate benefits for that beneficiary and avoid beneficiaries having future coverage issues. So this MSA data would be submitted for all workers' compensation total payment obligations to the claimant or TPOCs, and that's regardless of value or whether the MSA was submitted. So that MSA data is going to be reportable regardless of whether that MSA is submitted to CMS through the voluntary reporting process or whether it was a non-submit product using evidence-based medicine. CMS wants to know for the workers' compensation settlements what that MSA amount is going to be. Reporting is also required even if ongoing responsibility for medical is ongoing for some injuries associated, but were settled out for others. So if you've made a TPOC for that work comp settlement, you're going to have to report that MSA information through Section 111 reporting. I do want to note the only exception to this is going to be those existing workers' compensation TPOC reporting exclusions. So I believe it's settlements under 750 right now for work comp don't need to be reported, but otherwise you're going to have to report that information to CMS. So it is very important to take note of these. Like I said, it's going to be right around the corner. And if the reporting doesn't happen or any responsible reporting entity knowingly reports false MSA information, they could be in the position to face enforcement actions from CMS, which may include some False Claims Act litigation. So now's the time to start preparing for this, looking at this and talking to your Section 111 vendors about that. So Heather, do you have anything else to add on this topic before we move forward?
Yeah, I think I just want to reinforce two of the things that you said. Well, first of all, the False Claims Act potential, potentially coming out of reporting false MSA information. Medicare mentioned this on one of their webinars recently when they talked about this new WCMSA reporting requirement that they might have a potential action for a False Claims Act if this information is reported incorrectly or known in a false manner. And I think that's pretty scary stuff, right? Because False Claims Act can be significantly expensive, and who knows what other legal actions may come about if parties don't heed this. And the other thing I do just want to reinforce what Brenda has said is that you should definitely make sure, to the extent your entity is doing Section 111 reporting to Medicare, that your reporting agent is ready to report these 7 new data fields. Very, very important. You know, it seems like, oh, 7 data fields, but I'm sure many of you are familiar with how IT departments have a very long list of things to do for companies. And, you know, they have a lot of other important things going on. But if these fields are not reported starting in April, or these fields are not set up and ready to go in your system, you could face penalties for failure to report this information. So I would double check with your reporting agent, make sure that they're ready for this upcoming reporting requirement.
Now we'll talk a little bit about these additional MSA fields that are added. So this slide is an overview of the fields with a description and whether they are required fields or not. So take note of the required fields, which are your MSA amount, your MSA period, which that's the period the MSA is intended to cover, whether it's a lump sum or annuity. And if it is going to be annuity, they want to know the initial deposit and then that annual deposit amount thereafter. So those are the required fields that are going to need to be reported. And the really important thing to note here is if you report an incorrect value for one of the required fields, that is actually going to result in a hard error. That means your record is going to reject. So you are not going to be in compliance with reporting that claim in the eyes of CMS if you don't correct that appropriately and timely. So if that responsible reporting entity fails to re-report properly, then you look to have exposure for civil monetary penalties due to late reporting. So that's why these additional fields are really important to make sure you are ready to report those next April, working with your vendor to make sure that they are testing, which the testing of these new fields is going to begin next week on October 7th. So make sure that your vendor is prepared to participate in that testing, assesses the results, and make sure that everything is good to go by April. Heather, with these new MSA reporting requirements, do you think CMS is going to scrutinize under threshold settlements?
That's a great question, Brenda. I think, you know, there's no way to know for sure. You know, when we asked Medicare about the intent behind now requiring this MSA reporting, they seem to indicate it was all about coordination of benefits, right? They've been in the dark about non-submit MSAs, or even after MSAs are submitted to them, they don't know whether that MSA was actually funded, and so they want to be able to coordinate benefits, meaning deny payment if they know there's an MSA there, right? So that's what they said. But I do think, you know, Medicare will be looking at this data, right? So Medicare has said, even in their reference guide, that under threshold settlements still need to protect Medicare's interest, right? Medicare's workload thresholds in which they'll review an MSA are simply that, they're workload thresholds. They are not a safe harbor from needing to protect Medicare's interests. So to answer your question in a long-winded fashion, Brenda, I do think that Medicare will be scrutinizing under threshold settlements, or I do think they will be looking at the trends of data overall. Just looking at, you know, if you're a work comp payer and you're consistently not populating MSA values on your work comp settlements, and it's clear that this person's going to need future care, I think that's going to cause some scrutiny from CMS. And I do think that this is something that you all should really be looking at closely, especially beginning in April.
Yep, agreed. Thank you very much. We're going to shift gears a little bit and discuss some of the work comp MSA allocation practices by the WCRC. And it's really important to understand how the WCRC and CMS look at work comp MSAs. That way you can fully understand your settlement exposure. And like Heather said, you know, kind of analyze on a case-by-case basis whether you want to take advantage of the voluntary submission process or not. So the best resource to do this is the Work Comp MSA Reference Guide. We have a link to that on this slide. And we also have some of the allocation practices that can prove problematic for MSAs here. The first one is the fact that the WCRC will not allow for future weaning of medications. So Heather touched on this, and while it's particularly troublesome for someone who's taking opioid medications or something like that that has risk, it does apply to any medication a patient is taking. So pretty much the way CMS looks at it is that they want the weaning process to take place before it's submitted. Whatever that patient is taking at that time is what they're going to allocate. They're not going to assume future weaning can take place or that future weaning will be successful. So those types of things you want to look at before you submit that MSA to CMS if you're taking advantage of that voluntary process. There are also no means by which CMS allows a claimant to waive their right to certain treatments related to that workers' compensation claim to get it removed from their work comp MSA. This situation frequently occurs with things like surgeries, spinal cord stimulators, or intrathecal pain pumps, those more invasive treatments that are recommended. Sometimes these claimants just don't want to go through an invasive treatment. They don't like that option and they know they're not going to proceed. Unfortunately, that type of evidence or information is not taken into consideration by CMS. The only thing that they will accept to remove it from a work comp MSA is an actual statement from the treating physician saying that that treatment is not medically indicated or not recommended for that individual. And then also ambiguous language in medical records can be problematic for work comp MSAs and can lead to inflated allocations for treatments that are not probable, for medications that are not currently prescribed. It's very common to see in medical records a full history of all the medications that that claimant has been on for the lifetime of the claim. Sometimes the doctor's office or just doesn't update that information, or they're using an online program where they're limited in what they can do. And when all of that information is in there, if it's not clear cut what the patient is currently taking for medications, you could have CMS include medications that are no longer being prescribed. So those types of things that are not clear cut are things you may want to look at before you submit that to CMS. That way you can avoid having that counter high allocation with treatments that are not indicated for that individual. So now we'll talk about some of the more common cost drivers that we see in work comp MSAs. And the first one is those spinal cord stimulators, intrathecal pain pumps, and surgeries. It's very, very common to have a doctor just casually mention one of these items as a future treatment for a patient. If it's mentioned like that, even one time in the last 2 years of records you're submitting to CMS, CMS is going to allocate for it. It may not be evidence, supported by evidence-based guidelines. The claimant may not want to have it. It's possible it was recommended a year ago, but the patient's having some conservative treatment that is providing adequate pain relief. So it's just not an option anymore. Those things really need to be addressed with the provider before you submit that MSA, or you're going to have a costly item included. If you look at injection therapy, the WCRC is generally going to defer to the current frequency of those injections, regardless of whether there's efficacy or evidence-based guidelines support the ongoing use. So if you have someone who had, 8 or 10 trigger point injections over the last year, you're probably going to see 8 or 10 trigger point injections included over lifetime by the workers' compensation review contractors. So review the medical records. You want to look and see if the claimant's actually getting benefit from it. And if not, address those items with the provider and then use those evidence-based guidelines as your backup for the discussion. Office visits, we see those as being inflated and excessive at times. And even though physician visits not a high cost item, that can really add up over time. If your claimant is being seen by their pain management doctor every single month, 12 times a year over a 20-year life expectancy can be $10,000-$20,000 of your MSA, and it's not likely needed on that type of a continued basis. Even if someone's on an opioid, a scheduled medication like that, if they're stable, they can be seen quarterly. That's the general standard. And then if they're not on a scheduled medication, someone can even just be seen yearly or as needed depending on the medications that they're taking. So talking to the doctor and asking them about what that reasonable frequency is can really be beneficial to getting a more reasonable MSA amount. So now we'll shift gears and Deanna will cover cost drivers and prescriptions.
Hi, thank you, Brenda. I know that Brenda talked a little bit about the weaning, and it is not taken into consideration, even if the primary care physician has recommended weaning. CMS will allocate medications based on the current utilization at the time of submission or prescriptions that have been recently provided. So if there's an opportunity for weaning medications, it is best to address this with a physician prior to the submission, and also assuring that the claimant is on the lowest effective dose. This is something that should be assessed, especially when it comes to opioid medications. Like she said, it is beneficial to have that claimant on the lowest effective dose. We've all seen what the opioid epidemic has done. It can, having that lowest dose can lead to less side effects, decrease the potential for addiction, and just overall general health. If a brand name medications are being prescribed, it's best practice to verify if there's a generic equivalent and to discuss that utilization of a more cost-effective generic formulation with a treating physician. So we know generic and brand name drugs work the same. According to the FDA, generic medications are just as effective and safe as their branded counterparts. However, generic medications typically cost about 80 to 85% less than the brand name medications. And this can be a very simple way to reduce cost. How many times have we been in a retail pharmacy store where we grab the retail pharmacy brands or the generic of that name? We know they work the same. 99% of the time, the benefit is going to be the same. So I'm going to talk about some medications that cost more due to the formation or being a combination medication, which is essentially just two medications available separately that are now combined into one tablet or capsule. So for example, ondansetron or Zofran is the medication that's prescribed for nausea and vomiting. And in the workers' comp world, it's commonly prescribed when the claimant is experiencing side effects due to taking opioid medications. It is available as an oral disintegrating tablet or as a regular tablet. Now, as you can see on the screen, the oral disintegrating tablet costs significantly more, and there's generally no valid reason for the claimant to require that formation. So asking or talking with the physician just to see if they could switch, maybe even on a trial basis. Sometimes they're more apt to say they'll try something than just say, well, can we just switch this? So having that conversation up front with the physician can go a long way and can switch from the regular tablet and provide significant cost savings up to $36 a dose. Another example is Duexis. This is a combination of ibuprofen and famotidine, which is just Pepcid, but it's combined in one tablet. So the cost is approximately $33 a dose for this combination medication. If the claimant were to take two medications individually, so the ibuprofen and the Pepcid, the cost would be reduced to 12 cents a dose. So that's almost, $20 or $32 in savings for just each time they take that medication. I do want to mention that there are rare instances where this could be a valid reason for the claimant needing that certain formulation, but that's the exception and not the rule here. So things should be just discussed with the physician and see if they're willing to trial it, the medication formation change. Over-the-counter medications, or OTCs, are generally excluded from a WCMSA unless they're dual designation. And that means that they are available both as prescription and over-the-counter. It's good to keep this in mind as there are situations where an over-the-counter option is available. For one, we saw that Narcan is recently now available over the counter. This was just in the last year. The example here on the screen, lidocaine 5% patch is a prescription and costs $2.60 a patch, where lidocaine 4% patch is an over-the-counter and costs 73 cents per patch. So while the dosage is not exact, many times the physician will consider prescribing the 4% patch with similar benefits. Since this transition is not an equivalent 5% to 4%, this may not be an option in all the cases, but when it is medically feasible, this can provide a significant cost savings. And then lastly here on lower cost alternatives in the same medication class should be considered. So triptans are a class of medications used to treat migraine headaches. And there's a wide variance in prices for these medications, ranging from $61.46 to $2.25 per dose. So these are just some examples that highlight the things that need to be looked at the time of MSA preparation and brought to the attention of the claims handler for review for possible further action in making the claim more attainable for settlement. Now let's talk about the approach for mitigating MSA costs. Generally, it's best to address cost drivers early in the claim process, ahead of settlement and prior to the MSA if possible. In a perfect world, adjusters are plenty of time on their hands and they should proactively be reviewing those medical records and address costly treatment and medications. There could be some huge savings benefits if they find that time to look into these records and approach it prior to settlement, and the MSA would not be inflated. So also as a team approach, it's generally the best option here. If a case manager is managing the case, they would likely be the best resource to address issues with the prescriber and get the answers that are needed. Also, with the utilization review process, this can be a great tool to use in the MSA, and it will drive the treating physician to appropriately address the treatment that they're recommending. Although CMS will not abide by a UR determination on their own, it is important to monitor the case and assure that the physician is adhering to those UR decisions. Maybe it just needs to be sending a copy and asking for their feedback, and they would agree with it. Just sometimes if it's just put in their face, they read it, oh, that makes sense, and they would agree with that treatment recommendation. CMS is typically very black and white on the stance of payments, though. If you make payments, that is seen as an admission of acceptance for that condition. So if you pay for one injection and then we have an evidence-based or UR that's saying no further injections are indicated, if you've paid for it, you've accepted it, Medicare will most likely put additional injections in. Only related treatment should be provided. And if it's unclear if treatments are for the accepted conditions, address that immediately with the physician. Have them clarify if they list anything that's a comorbid or a personal condition in that assessment or in those diagnoses that are being treated under that data service. And lastly, an experienced vendor, a vendor partner, working together as a team should be willing to assist the adjusters in navigating that cost mitigation and provide recommendations on how to get those accomplished. So in addition to adjusters proactively monitoring treatment costs and recommendations, these opportunities can be addressed either through a pre-MSA, which is a precursor to a full MSA report, where the case is reviewed and key cost drivers are identified and recommendations are providing for achieving that MSA reductions. Also, during the normal MSA, WCMSA process, identification of any issues that could inflate the MSA should occur. So this would include treatment gaps, missing information, ambiguous treatment recommendations that could possibly need to be clarified, or cost drivers for both medical and prescription medications. And lastly, where a treatment letter is needed from the provider to possibly confirm that last date of treatment if treatment has abruptly stopped with no further recommendations. So when we leave the room for interpretation, it generally puts the WCRC in a position of allocating to that worst case scenario. In turn, this can inflate that MSA. And you would be surprised coming back with more than just a 22% higher counter. So one more thing I do want to mention is that not every item is costly, warrants mitigation. Brenda, what are your thoughts on mitigating all high cost items?
Yeah, that's a good point, Deanna. It's not every high cost item is going to have a mitigation opportunity. There are going to be medications out there that just don't have a lower cost alternative for them. And if there they're appropriate for treatment of that claimant's condition, then, rightfully they belong in the MSA. You could also have a costly surgery. A patient has a multi-level fusion recommended for them, but their diagnostics show that there's instability. They have those documented factors, and they meet guideline for it, so it's appropriate. So just because something has a high dollar value doesn't mean it can be mitigated, but you certainly want to scrutinize those high dollar value surgeries, medications, services, and assess whether they are appropriate for that case, whether they meet evidence-based guidelines. So it's really a case-by-case basis. And that's where partnering with a vendor who's knowledgeable in this area really can help.
Right. And taking that full picture, taking a step back and looking at claim as a full picture, seeing what diagnoses have been associated with that claim, and are they appropriate to support a multi-level fusion? Yeah, that's a very good point. According to the WCMSA reference guide, the WCRC will consider evidence-based guidelines, but it also states that these are just guidelines. They're not rules, and the final determination is also based on the claimant's past and future recommended treatment. The treating physician's opinion is generally what holds the most value. So evidence-based treatment guidelines are a great source, and while they are just guidelines and not hard and fast rules, they are to be used to support that conversation with the physician and leverage those recommendations for alternative therapies, or even remove the treatment that will allow for a medically indicated, safe, and effective future treatment plan. Our ultimate goal is just to assure that the treatment currently being provided or recommended is supported. It's supported medically, it's supported clinically, and scientifically. It provides benefit and is the most cost effective. Physicians should already be used to using this position, as it is typically how it works with the group health insurance. And sometimes we see that the physicians do not feel or take this stance, and they don't follow the same medical guides as a workers' comp claims. And these issues need to be brought to the table for discussion on them. There's nothing wrong with asking the physician those questions. Some evidence-based guidelines resources are ODG and ACOM. These are the two largest utilized guidelines. However, there are some state guidelines. So consider the jurisdiction that you're working with to determine the best guidelines for use of that claim. If some states have their own treatment guidelines, this should be followed or recommended in lieu of the ODG or ACOM. So here's an example of how evidence-based guidelines can be used. Case facts. It's a low back injury, chronic pain, surgical history with a diagnosis of severe depression. There's been conservative treatment of medications and ESIs, which have improved the pain on a scale from a 7 to a 3. And the patient's condition is noted as stable in the recent medical records. However, there is a discussion or a recommendation of an SCS. According to the ODG, an SCS may be indicated when all of the following are met: condition of a failed back syndrome related to surgery, lack of improvement with conservative therapy for at least 6 months, patient is capable of operating a stimulating device, a psychological evaluation is performed prior to the trial of the SCS, and that trial SCS is completed with a greater than 50% improvement in pain, that the SCS is a part of a multidisciplinary treatment plan, so it's not the only pain management regimen being implemented, and no anticoagulant medications or chronic infections with implantation. It would be acceptable to question the provider regarding the medical necessity of an SCS in this situation. When conservative treatment measures have not failed, they brought that pain down from a 3 to a 7, and it's unclear whether the patient is suitable for if the psychological evaluation will be cleared, and they have a diagnosis of depression. It's just a good conversation piece to bring these to the physician and question the treatment. So now we've discussed possible cost mitigation opportunities or key cost drivers. How do we perform an action plan? Some cost mitigations are more costly than others, depending on the claim and the condition. So the first, you have to verify that the provider outreach is an option and who is best suited to perform that outreach. You're going to want to assess whether there are jurisdictional rules that would prohibit outreach or ex parte communication. Ex parte communication occurs when there is a verbal or written communication between parties that are not shared with the opposing parties or the opposing party's lawyer. For example, the TPA, the carrier, or the vendor, and the treating physician. In some jurisdictions, claimant or attorney authorization needs to be attained before contacting a provider, and there may be different requirements for oral versus written communication. So if defense counsel is involved, this is a great resource for ex parte information and if it's applied. If outreach is feasible, and the end goal should be a written statement from that provider answering specific questions identified related to the treatment plan, or getting an updated office note if they have recently been treated. So sometimes if like Brenda mentioned, those cookie cutter medications that don't fall off the medical records, if you ask the physician, are these still being prescribed? When were they last prescribed? We can remove those from the allocation. When medication changes are implemented, CMS may want to confirm the transition of seeing a pattern in that refill history of 3 months or longer. They want to make sure that that prescription change is going to stick, like it worked. They're not going to come back and say, I'm in more pain, and then the physician changes back to that original prescription. This is not a requirement across the board, as a brand to generic change is simple, but there should be questions of the benefit. If the physician lowers the dose of the opioid medication, CMS may want to assure that that lower dose continues to provide that benefit.
Now we'll talk about a few actual case outcomes, just so you can see the impact of taking this proactive approach to mitigating these items. So this was a scenario where work comp MSA included a spinal cord stimulator, which was recommended a year ago. There was no clear-cut evidence it was medically indicated. There was no psychiatric evaluation, and the conservative treatment that was being provided was managing the claimant's pain. So you can see the allocation for that spinal cord stimulator was just over $138,000. They had the typical diagnoses you see with a low back pain on a comp claim, pain, inflammation, failed back syndrome. The spinal cord stimulator in this instance was not supported based on the evidence-based treatment guidelines. So as Deanna said, that was a scenario to have a conversation with the provider. So the spinal cord stimulator was addressed with the provider, that evidence-based guidelines were brought to the table, and the treating physician did put in writing that the spinal cord stimulator was not medically indicated for this particular patient. So that removal resulted in just over $138,000 in savings on this claim. So again, we talked about brand medications and their generic counterparts that are significantly less expensive. So if brand medications are prescribed, it's best practice, always verify if there's a generic alternative that can be provided, because the savings can be significant, as evidenced by this particular case where the work comp MSA included brand name Celebrex and Asafax to the tune of $290,000. So the provider was contacted to verify if generic medications could be prescribed. They did agree that generic medications could be utilized by this patient, and then that work comp MSA was ultimately submitted to CMS, who approved the allocation of the generic medications, but that was only $46,828. So doing that proactive mitigation saved over $243,000 on this particular claim. That's not just chump change when you're talking about a couple $100,000. And then this last example was one of those scenarios where the patient was being seen by pain management monthly. And as we said, CMS would require monthly office visits over the lifetime, which in this case was 18 years. It was around $35,000. This claimant's condition was stable. They had been on the same medications for the past 2 years, unchanged. There really didn't seem to be a reason that claimant had to be seen by their pain management doctor on a monthly basis. So a request was made to that provider to see if those office visits could be reduced quarterly. There was agreement to do that, and then the work comp MSA in this scenario was reduced by over $23,000 by reducing those office visits. So if you do a little bit of work up front, you can really have some benefit to your work comp MSA.
Great. So, Sanderson Firm can assist with your Medicare set-aside needs. We have our unmatched IMSA indemnified Medicare set-aside program. I talked about that earlier. We also submit our evidence-based MSA to Medicare. right? So similar methodology, right? Applying evidence-based guidelines to the allocation and submitting that to Medicare. And we've seen great outcomes from CMS. They are either approving our MSA as submitted or with a slight counter high. So we're having some great outcomes there. All of our MSAs are reviewed by our senior clinical specialist team to deliver the most accurate and defensible MSAs in the industry. Every MSA is reviewed by an attorney for quality control as well. And so we bring the best combined expertise from a legal and clinical standpoint. We also identify cost drivers and potential exposures. We will provide that information when we deliver the MSA and consult throughout the process to make sure our clients are getting the most cost-effective outcomes. We do have both medical mitigation, which is a service that we offer. We'll contact the treating provider on your behalf to obtain a treating provider questionnaire to address potential cost reduction recommendations. We also have a treating provider letter service. We'll produce a letter that our client can submit to the treating provider to address the potential cost reduction recommendations. So we can certainly customize these as well as it suits your needs. Just want to give a brief plug-in for our new certification coming about. Some of you might have heard of a few months ago in February, well, not that long ago, I guess that would be 7 months ago already, we released our Medicare Secondary Payer Accreditation, which is an online program that covers everything from MSAs to conditional payments to Section 111. Now, we realized that the industry needed an MSA-specific certification. There's really nothing quite like it. For those of you that want to brush up on your MSA knowledge or want to learn how to write Medicare Set-Asides, introducing Medicare Set-Aside Certified Planner, or MSACP for short. We are currently in pre-launch mode and are planning to go live shortly in just a few weeks with the full program. It consists of 10 to 12 hours of courses. It will give the history, principles, and development of a work comp Medicare set-aside. This program was facilitated by Sanderson Firm and Work Comp College, much like the MSPA program. We have some great faculty on the program. Both Deanna and Brenda are teaching a couple courses. We have many of our clinical team teaching courses. We've also brought in some other outside faculty from the work comp industry experience with MSAs. We cover everything from importance of records and prescription history, steps to complete an MSA, CMS submissions, non-submit and evidence-based MSAs, and mitigation strategies. This course can be taken by anybody working in MSP compliance, work comp, legal fields, perhaps nursing graduates, claims professionals. No prior experience is required. If you'd like to take advantage of our pre-launch, that's available at www.mspcollege.com. If you have any questions on the program too, we are available to answer those as well. And there are some FAQs on the website as well to address the most common questions we've received. We've already had a few folks register for the course during our pre-launch, which is very exciting. And we know that there will be more to come. So what great information you all presented today, Brenda and Deanna. So thank you for that. Looks like we do have a couple of questions here. Okay, the question is, for MSA reporting requirements for settlements, is there a monetary threshold for reporting? For example, only settlement over $250 needs to be reported, or do all settlements need to be reported regardless of settlement amount? I'll take that. So the reporting threshold to actually have a reportable claim under Section 111 is that the settlement has to be at least $750 or greater. So you're only going to report TPOCs on settlements that are $750 or greater. And in that instance, you would report, but if the settlement is only $250, as was provided in this example here, that would not be reportable. There would be no MSA reporting requirement. But on all settlements that are reportable under $750, those would be reportable. You would need to fill in the MSA fields. Even if there is no MSA, you would need to report that. I think that's it. We don't have any other questions at this time. I think we just answered all of their questions so well today that they're fully satisfied. So thank you so much for attending today. Wishing you all a great, wonderful day. And thanks again, Deanna and Brenda, for your time and sharing your expertise today. Have a good afternoon.
Very welcome.
Bye-bye.
Bye, everyone.